Hello everyone, welcome to the first lecture in the glaucoma lecture series sponsored by MediTread, a website dedicated to online medical education and training. Today's topic is pathophysiology of glaucoma. I am Dr. Ramesh Ayala from Tulane School of Medicine, New Orleans, Louisiana, USA. Here are my financial disclosures. Of note, I am the president and part owner of MediTread.com, the website that is sponsoring this educational series. So what is glaucoma? It's a group of diseases that have in common a characteristic optic neuropathy associated with vision field loss, for which elevated intraocular pressure, or IOP, is one of the primary risk factors. Remember, 20 years ago, people used to equate glaucoma to elevated intraocular pressure. We know better now. We know that IOP, or elevated IOP, is one of the main risk factors, but there's also a whole group of glaucoma patients out there where the intraocular pressure may be normal, but they have vascular dysregulation, which is the main reason why they develop glaucoma-related vision field loss. If you look at the picture that's pointing out here, and let me see if I can draw to outline what we're talking about. Glaucoma causes changes in the optic nerve, which are very peculiar in the sense that it enlarges the cup-disc ratio of the optic nerve head, leading to loss of the axons, which in turn lead to vision field loss. So let's look at the prevalence of the disease and the pathophysiology of this disease process. There are about 100 million people afflicted with this disease process worldwide. 8 million blind worldwide. That's about 15% of the patients who have glaucoma. They are blind from glaucoma. It's a irreversible blindness, unlike cataracts, which can cause a reversible blindness, i.e., if you operate on the cataract, the patient is going to recover the vision. Whereas with glaucoma that's left untreated, it's going to cause permanent loss of vision. In the US alone, there are approximately 2.25 million people afflicted with this disease over the age of 45. And there are about 100,000 patient population with bilateral blindness in the US. It's estimated that the incidence of glaucoma is going to increase to 3.36 million by year 2020 as the baby boomers will come off age. Remember, this is the most frequent cause for non-reversible blindness among African descent population. Among the white population over the age of 40, the incidence of glaucoma is 1.1 to 2.1%, whereas in African American descent people, it's 3 to 4 times higher, with 4 times higher likelihood of blindness. The family history, positive family history, increases the risk by 3 times. Whereas because of its polygenic inheritance pattern. Factors associated with glaucoma include elevated intraocular pressure, greater than 21 millimeters of mercury, which is one of the main risk factors that we talked about. Age, below the age of 50, the incidence of glaucoma is less than 1%, but it increases to 4% of the population over the age of 70 years of age. As mentioned previously, African descent population are 4.3 times higher likelihood of developing glaucoma compared to white population. More recently, thin corneas has been recognized as an independent risk factor in the study that was done 2 years ago. What has come to be known as the OARD study, or ocular hypertension study. In that particular study, which we will discuss in detail at a later date, it's been recognized that thin corneas, patients with corneas less than 550 micron cornea thickness, or at a higher risk of developing glaucoma, and this has been identified as an independent risk factor, independent of its association with intraocular pressure measurement techniques. As mentioned previously, positive family history also carries the risk of developing glaucoma. The Baltimore study identified that among the white population, there is a 3.5 times higher likelihood of developing glaucoma over the age of 70 years when compared to those below the age of 40 years. For the black population, this ratio is 7.4. There is no gender association in relation to primary open-angle glaucoma. Factors with moderate association include myopia. There is no sex correlation as far as primary open-angle glaucoma is concerned, but in the special category of normal tension glaucoma, you will see that it's more common in female patients compared to males in the ratio of 2:1. Diurnal variation of intraocular pressure, or in other words, a fluctuation in intraocular pressure right through the day of greater than 8 to 10 millimeters of mercury is known to be associated with development of glaucoma. So this is a definitive risk factor that you need to watch out for. And one way to identify this is by doing serial tonometry, which is to check the intraocular pressure right through the day. Typically, in my practice, I bring the patient in first thing in the morning, say at about 7:30, and check the intraocular pressure at least a couple of times in the morning, and a couple of times in the afternoon, and a couple of times in the late evening. And that way you will have 4 to 6 readings throughout the day. And if the peak pressure is greater by more than 8 to 10 millimeters of mercury from the lowest intraocular pressure reading for that particular day, that increases the risk of this particular patient from developing glaucoma. Weak associations, there are certain diseases that are associated with it, but the association has been categorized to be weak. These include diabetes, migraine, and other vasospastic disorders, especially in relation to normal tension glaucoma. Sleep apnea, again in relation to normal tension glaucoma. So remember, vasospastic diseases and sleep apnea are linked to normal tension glaucoma, whereas systemic hypertension and diabetes are supposed to be weakly associated with the primary open-angle glaucoma. Now, this may be because glaucoma is an older age disease population, like we just mentioned, and diabetes and hypertension are also older age disease processes. And as such, it is no surprise that you see all three diseases in the same patient population. It may be one of those coincidences. But certainly diabetes in itself can cause a different kind of glaucoma called neovascular glaucoma, a topic in itself that we will discuss much later in this lecture series. But for the purposes of primary open-angle glaucoma and this lecture, it's important to remember that there is a weak association that's been described between diabetes, hypertension, and primary open-angle glaucoma. In regards to hereditary and genetic factors leading to glaucoma, most glaucomas are of autosomal dominant inheritance that may involve more than one gene with late age of onset and variable penetrance. Remember this. For those of you who are taking your boards or preparing for your exams, wherever you're located, this is a frequently asked question. There are a couple of exceptions. Steroid-responsive glaucoma is supposed to be an autosomal recessive disorder. So what is the driving factor here? Mutations in the myocilin protein produced by the trabecular meshwork cells is supposed to alter the pathway of the aqueous across the trabecular meshwork into the Schlemm's canal in such a way as to increase the resistance to the outflow, thereby increasing the intraocular pressure. Now, GLC1A is the responsible gene for myocilin mutation, and it's mapped to chromosome 1. This again is an important question from your exam point of view. This is also the first open-angle glaucoma gene that's been identified approximately 10 12 years ago. It's seen in 3% of the primary open-angle glaucoma patients. I remember when this gene was first identified, there was a lot of hope that a lot of the population at risk can be screened for this particular gene. And as it turned out, this is present only in 3% of the population with primary open-angle glaucoma. And so there are a lot of other genes out there that are yet to be discovered, a topic that could be of interest for those of you who are interested in research that will help us understand the pathophysiology of glaucoma much better. Now, congenital glaucoma, similar to the steroid-induced glaucoma, is of autosomal recessive nature. The gene that's linked to it is CYP1B1 gene. The rest of the glaucomas that are listed here, they're all autosomal dominant in nature. The juvenile open-angle glaucoma, primary open-angle glaucoma, angle closure glaucoma, pigment dispersion glaucoma, and Rieger syndrome. They're all of autosomal dominant nature. So remember, as far as glaucoma is concerned, the steroid-induced glaucoma and congenital glaucoma are the two autosomal recessive disorders. The rest of the glaucomas, from the exam point of view, should they ask you, is of autosomal dominant inheritance pattern. From the exam point of view, again, among the glaucoma genes, remember some of this. CYP1B1 is related to the primary congenital glaucoma, PTX2 Rieger syndrome, FOXC1 iridogoniodysogenesis, and LMX1B nail patella syndrome. As to why you should remember this, it's purely from the exam point of view. If there are any geneticists who are listening to this lecture, of course, this will stimulate interest in you, but for most of practicing clinicians and residents in training, you need to at least have a primary basic understanding of these genetic defects that are associated with glaucoma, and remember these specific genes in relation to your exams. So the initial insult in glaucoma is related to the exoplasmic flow at the lamina cribrosa, which is caused by elevated intraocular pressure and vascular dysregulation. This leads to the secondary insult, which includes excitotoxic damage from glutamate or glycine released by damaged neurons, and oxidative damage from, say, elevated nitric oxide in that environment. And the end result of both the initial and the secondary insult is death of the retinal ganglion cells, or RGC, which stands for retinal ganglion cells death, which leads to permanent vision field loss. So remember this, the initial insult is supposed to be an exoplasmic flow insult at the lamina cribrosa, caused either by or a combination of elevated intraocular pressure and vascular dysregulation. This leads to secondary insult, which includes excitotoxic damage from the released glutamate or glycine by the damaged neurons, and oxidative damage by elevated nitric oxide, and a lot of remodeling of the extracellular matrix in MMP that leads to retinal ganglion cell death and permanent vision field loss. So let's move on to the etiology of glaucoma. There are three theories to describe the etiology of glaucoma: mechanical, vascular, neurological. If you look at this cartoon picture that I share here with you guys, you can see the optic nerve right here, and the million plus axons which form the optic nerve head. The axons, of course, originating from the retinal ganglion cells and coming towards the optic nerve head in a peculiar fashion that's described here. And I hope all of you are aware of the anatomy of the axons and the way the optic nerve head is formed. So I'm not going to go through that as part of this lecture. Loss of these axons, especially if, for example, in this area where you have the darkly marked axonal fibers, would lead to a vision field loss, corresponding vision field loss involving the superior arcuate area, which is the classic defect that you see in patients with glaucoma. So let's go through the different theories that explain as to why this happens. The mechanical theory is based on elevated intraocular pressure. Elevated intraocular pressure leads to structural changes in the trabecular meshwork, cytoskeletal changes in cells, altered cellularity, and extracellular matrix changes. This leads to retinal ganglion cell death from apoptosis. The retinal ganglion cell death occurs in two stages. When these cells are exposed to elevated intraocular pressure on a persistent basis, in the acute phase, for example, if a patient develops a pressure spike of 60 or 70 millimeters of mercury, in the acute phase, what happens is that in the first 3 weeks, there will be a 36%, approximately 36% loss of retinal ganglion cells from apoptosis. So there is a direct destructive effect of the acute elevated intraocular pressure on the ganglion cells. So we lose them at approximately 12% per week or 36% in the first 3 weeks. After that, the chronic phase kicks in, where there's a slower RGC cell loss from toxic effects from the primary RGC cell death, i.e. when these cells die, they spit out glycine and glutamate into the surrounding environment, and that excess glutamate and glycine is toxic to the adjacent normal ganglion cells. We will discuss that a little later in this conversation. And elevated intraocular pressure exposure. So if the IOP elevation persists, in its presence, along with the primary the apoptotic cell death, and the released chemicals, excitotoxic chemicals that are released secondary to the RGC cell death, will lead to the second stage or the chronic phase of slower RGC cell loss. So the mechanical theory states that elevated intraocular pressure leads to mechanical compression of the axons at the lamina cribrosa. A lot of stress is being placed in this area of the lamina cribrosa. As you know, this is the junction where the axons exit out of the eye and cross the sclera into the retrolaminar portion of the eye. So the changes that happen in the lamina cribrosa are supposed to be causing mechanical compression of the axons and the axoplasmic flow, and the elevated intraocular pressure being the main culprit in this regards. Axonal compression leads to blockage to the orthograde and retrograde axonal transport, as you can imagine. And this is pretty easy to imagine. Here is your axon, and there is a flow of fluid, transport material coming to and fro from the eye and away from the eye. And if you compress this with elevated IOP, then you end up with axonal compression. And once you compress this axonal axon and there is no more flow in this area, then you got a problem in the sense that the ganglion cells from where this is originating from is going to die. And that's the mechanical theory for you. Characteristic, this leads to once the axon, the ganglion cell dies and the axon dies and shrivels up, you will have a characteristic disc cupping with rim loss. So if this is your normal optic nerve with a healthy rim, as more and more of these axons which form the rim here die, you will end up with a large cup, what we describe as large cup with a very thin rim or almost absent rim. If you look in this area, there is no rim at all, and that essentially tells you that all the axons in this area are dead, right? And this will lead to permanent vision field loss that you can pick up on your Humphrey vision field testing. So what is the optic nerve head? we're talking a lot about this optic nerve, and so I think it's time for us to talk a little bit about the anatomy of the optic nerve head. Optic nerve head is made of 1.2 million axons. The origin of these axons is from the ganglion cells, so these are unmyelinated nerve fibers. They connect the retinal ganglion cells to the lateral geniculate body, and when you measure the diameter of this optic nerve head, it measures approximately 1.5 millimeters. And this is an important statistic for you to remember, both from the practical point of view and also for your boards. And so here is an example of a normal looking optic nerve. You can see that the central white depression is what is called as a cup, and you can see a healthy pink rim surrounding it. So when they talk about cup disc ratio, what they're talking about is if you take the entire optic nerve head is 1, you want to have a ratio between the size of the cup to the entire cup disc, the entire optic nerve head. And so if it's 50% of the optic nerve head, that's the cup, then you say it's 0.5 cupping. If it is 80% of the optic nerve head, you call that as 0.8 cupping. And you got to remember that when you look at your optic nerve, there is a central area of pallor where the lamina cribrosa is located. You should not mistake that to be part of the cup. A lot of times in healthy optic nerves, this central pallor is the same size as the cup, but in patients with disease process, the cup certainly is different from the central area of pallor that you see, which is reflective of the lamina cribrosa area. And so try and understand and examine the optic nerve with your 90 diopter lens or 76 or whatever lens that you have, and to study the optic nerve as you go about examining these patients with glaucoma. Extremely important for you to do that and document what you see. That's another important step. So, for example, in this case, the cup could be like this. This area is the central pallor. And if you consider this to be the cup disc ratio as the cup, then it's only 50%, but the actual cup could be as large as this. That will be 75% of the optic nerve head, right? And the way to make this distinction is to follow the blood vessels. The origin of the blood vessels as they cross over the rim of the optic nerve is what I look for. Here, as you can see here, it goes flat, 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 and then as it dips from the bottom of this cup to the rim, you will have a distinct nick in the blood vessel. That's where the cup ends. So you can see in this example, this portion of the rim is much thinner compared to this portion. So the superior portion has got what appears to be healthier rim compared to the inferior portion. And if this is really from glaucoma, for example, in this area, there is a lot of loss of axons, then it will be reflected by loss of vision fields in the superior arcade area. So the structural changes in the lamina cribrosa are becoming more and more important, and this is a complex topic to understand in itself. And I encourage you to search the literature to read structural changes on lamina cribrosa being published in the literature, mostly from monkey models. So the elevated intraocular pressure is supposed to cause increase in the hydrostatic pressure gradient across the lamina cribrosa with posterior bowing of lamina cribrosa with mechanical deformation and stress. So the stress-related damage leads to astrocyte migration from the nerve bundles, MMP or matrix metalloproteinase release, which leads to remodeling of the extracellular matrix, weakness in the lamina, and posterior bowing. And along this pathway, what happens, you will hear a lot about two things here: the extracellular matrix and MMP or matrix metalloproteinase release. And between the two of these, it's supposed to alter the environment in that area, leading to cell membrane damage and loss of axonal flow and loss of retinal ganglion cells. Here is a table that I borrowed from a great publication that was published in 2009 in the Indian Journal of Ophthalmology by Renu Agrawal, I believe, and I will give you the reference to this paper that I would like for all of you to read. It's a great summary of all the literature current thinking about the pathophysiology of glaucoma, and what they're showing here is the molecular response to elevated intraocular pressure as far as literature, published literature can understand. So elevated IOP, which is what we all know is associated with glaucoma, will lead to decrease in the growth factor, leading itself to apoptosis of the retinal ganglion cells. It can also cause mechanical damage and increase in glutamate, both of which can lead to increased MMP expression, which in turn can lead to apoptosis. Also, the elevated IOP increases the TNF or tumor necrotizing factor alpha increase, and nitric oxide oxidative stress increase around the retinal ganglion cells, leading to apoptosis. So all three mechanisms: growth factor alteration, direct mechanical damage, glutamate, the glutamate increase, TNF alpha increase, nitric oxide, and MMP expression increase leads to apoptosis of the retinal ganglion cells. So the MMP1 and 9 and TNF increased expression leads to extracellular matrix damage, which in turn contributes to retinal ganglion cell death. That's how this theory is supposed to work. Let's move on to the vascular theory. And these theories overlap, remember? I mean, even though we're talking as distinctive entities, a lot of these, all three theories at the end, you will understand, overlap. And there is a great table again in the same paper that I'm referring to that I will share with you at the end of this lecture that ties the three theories leading to RGC loss. So the vascular theory, for you to understand the vascular theory, we have to take a step back and understand the optic nerve head vascular supply. So the optic nerve head is supplied by two systems, okay? Remember, two from your board's point of view. Central retinal arterial supply system that supplies the inner retina and the surface of the optic nerve head in this area, okay? In this area, right? And then the short posterior ciliary artery branches that supply the lamina cribrosa and the retrolaminar axon. So we go from this area all the way to the back. This portion is supplied by the short posterior ciliary arterial branches. Now, why is this important for you to know? Increase in the intraocular pressure leads to compression of the vasa nervosum of the retinal axons, loss of autoregulation and blood leakage, axonal death, which in turn will lead to ganglion cell death. So the microvascular changes in vasospasm are also known to play an important role in normal tension glaucoma, which we will discuss as a separate entity in itself later on in this lecture series. What I want you to understand here is that each axon, let's imagine this to be an axon, has an individual blood vessel supplying nutrition to it. If you expose this blood vessel to elevated intraocular pressure, I see if I can write this out for you, IOP, okay, there. Increase in IOP leads to compression of this blood vessel. Remember, a blood vessel is a collapsible tube. Anytime you surround a collapsible tube with a rigid chamber, which is the eyeball, and increase the pressure in the rigid chamber, it will cause collapse of the collapsible tube, i.e. the blood vessel. Once the collapsible tube collapses, i.e. the blood vessel, there's no more blood circulation going on. And so this axon is not going to receive any more nutrition from this collapsed blood vessel, leading to axonal death, which in turn will lead to the retinal ganglion cell from which the axon is originating to die. Also remember a couple of other points. Optic nerve head is considered a watershed area. There is a pressure difference between the intraocular pressure and the intracranial pressure. Okay, intracranial pressure can also affect the axoplasmic flow. So either an increase in the intraocular pressure or decrease in the intracranial pressure can affect the axonal flow, causing axonal death. There is a paper that came out of Mayo, Rochester. I recommend that you look it up and read that paper that put forward this theory of patients having low intracranial pressure presenting as normal tension glaucoma patients. So it's an important theory that has not been validated in larger studies, but it's an interesting concept, and if you believe in pure physics, I think this does make a lot of difference between the IOP and the ICP. Either increase in IOP or decrease in the ICP, both can affect the axoplasmic flow, consequently causing damage to the axonal flow. So the vascular issues in relation to the molecular mechanisms goes about like this. Vascular dysregulation, for whatever etiology may be, here we assume that this is from elevated intraocular pressure. It leads to increase in endothelin, increase in TNF alpha, increase in the glutamate, and nitric oxide and other oxidative stress leads to increased MMP expression, which in turn leads to apoptosis or cell death. Apoptosis is nothing but programmed cell death that's very well described in the rest of the human body, and here we are applying this concept to the retinal ganglion cells. The neurological theory goes about like this. Elevated IOP, which is the initial insult, leads to ganglion cell death. When the cell dies, it's going to spit out glutamate, which is the normal excitotoxin that's located in the cell. Now that the cell is dead, it's going to spit out the glutamate into the surrounding environment. Increase in the extracellular concentration of glutamate leads to apoptosis of the adjacent ganglion cells. And I'll explain this to you a little bit more in detail in the next few slides. There's a role of free nitric radicals, oxidative stress, and immune-mediated axonal damage that play a role in this neurological theory. So here is how the glutamate excitotoxicity is supposed to work. Extracellular glutamate stimulates the NMDA receptors. Okay, so this is how this is supposed to work right here. The NMDA receptors that are sitting on this complex here, if glutamate that is released from an adjacent dying cell, let's imagine that this cell here is dead, it's going to spit out glutamate into the environment there, and this excess glutamate or glycine is going to go sit on this NMDA gate. Once that happens, this NMDA gate is the one that regulates the sodium and calcium inflow and outflow in the cell. And you will have excess calcium and sodium inflow from the extracellular location into the cell. Excess calcium in the cell leads to cell death. It is not clear if glutamate excitotoxicity is an initial response to elevated intraocular pressure in ischemia or secondary response due to release from dying ganglion cells. In either case, it appears to influence retinal ganglion cell death. A lot of this research came out of Massa, India from Evan Dreyer's lab. I recommend you to read his original literature published in Archives of Ophthalmology about glutamate and its concentration increase in posterior vitreous cavity in glaucoma patients and in animal models. There are other factors that people have identified in relation to ganglion cell death, and these include the brain-derived neurotrophic factor (BDNF), transported via retrograde axonal flow from the lateral geniculate body to ganglion cells. BDNF delivery obstructed by IOP, leading to cell damage. There's an interesting experiment that came out of Iowa State University Veterinary College, if I remember correctly, several years ago, where they delivered BDNF in a glaucoma model and showed that the ganglion cells survived the neuronal damage to the ganglion cells decreased in the presence of BDNF. And since the original publication, this group has not published anymore, unfortunately. So I don't know where that research stands at this point in time, but remember, BDNF can play, or rather the lack of BDNF being delivered from the lateral geniculate body to the ganglion cells can play a role in RGC death. Endothelin is another vasoactive peptide that is also recognized in this regards. It's found in higher concentrations in aqueous of glaucoma patients. Exactly how it causes damage to the ganglion cells is unknown. Endothelin is related to the damage to the axons, and there's a lot more research that needs to be done in this regards. And then lastly, nitric oxide. There's a lot of literature that's published, but none of these have any practical implications at this point, remember. Excess nitric oxide produced by astrocytes in microglia in response to IOP and ischemia leads to free radical production in the cell and disruption of cell functioning and cell death. A lot of literature is collecting not only in ophthalmology but in cardiology and neurology also, what the role of these free radicals and their impact on cell death. None of these have translated to clinical practice where we can utilize this knowledge towards neuroresuscitation. Neuroresuscitation, or the retinal ganglion cell resuscitation following injury, is still a dream at this point in time. So any of you young investigators interested in research, this is a wide open field for you guys to work on and maybe save lives in the future. So if you put together, again, this wonderful table I borrowed from the Indian Journal of Ophthalmology in the interest of resident education, published by Renu Agrawal, I believe. You can see that the elevated IOP gives rise to a variety of factors, and vascular insufficiency. Either this or this, elevated IOP, in both cases, in both situations, you will have growth factor deprivation, glutamate receptor upregulation, oxidative stress, nitric oxide activation and glutamate release, TNF alpha upregulation, and extracellular matrix change, all leading to retinal ganglion cell apoptosis. On the other hand, similar changes are also seen in relation to vascular insufficiency, which also contribute to retinal ganglion cell death. And just to cap this lecture, this topic of apoptosis, for those of you who don't know, apoptosis is a process of programmed cell death in the absence of inflammation, characterized by DNA fragmentation, chromosome clumping, cell shrinkage, and membrane blebbing. A lot of human body, especially you see this word apoptosis in ophthalmology literature or in neurology literature, etc. And as humans age and then they are in the process of dying, this programmed cell death takes over and leads to the eventual terminal event of human body. In this event, in the case of glaucoma, we believe that the instigating factor for this apoptosis is either elevated intraocular pressure or vascular insufficiency, or it could be a combination of both of them, leading to cell death, while several factors being let me rephrase this. Several entities mediate this cell death when exposed to elevated intraocular pressure or vascular insufficiency. I think that's a better way of putting this together. So the ganglion cell death leads to axonal death, vision field loss, that is seen on elevated on the Humphrey vision fields, and the retinal nerve fiber layer or thinning that's visualized on your OCT. So the final thing that you in the clinic can see in a patient with glaucoma, one is the intraocular pressure. You can measure the intraocular pressure, right? And then you can you can do a vision field test, and then based on that you can decide the vision field loss. And then using imaging technology such as the OCT, you can measure the retinal nerve fiber layer thickness in this area, and that will give you thinning of the retinal nerve fiber layer. So these are the factors that help you make a diagnosis of glaucoma. But at the molecular level, this is what cellular level, this is what is happening. Okay. Great slide again that I borrowed from somewhere. I have no idea where. Whoever put this cartoon together, I want to thank them. And in the interest of resident education, I think we should use this slide to explain the pathophysiology of glaucoma. Here is another cartoon version of ganglion cell death. It's a domino effect, initial cause, intraocular pressure, damaging stimulus, which could be any of the factors that I mentioned, like excess glutamate, glycine, extracellular matrix modulation, matrix metalloproteinase stimulation, and all of these factors, the oxidative stress, etc., all of this will lead to cell death. So the final end product that you see here is ganglion cell death, which leads to vision field loss. Now, the reason why you ought to know this is there is scope for therapeutic intervention. If you know the pathophysiology of how and why somebody loses their vision, maybe there is a role for us to intervene or devise smart interventions that may help these patients with this disease process, right? So, as can be seen, the primary intervention that we all deal with is decreasing the intraocular pressure. Almost 100% of glaucoma treatment is directed in this direction. They're all geared towards reducing the intraocular pressure. Can we improve the blood circulation or decrease the vasodysregulation that we talked about? Well, people tried calcium channel blockers and carbonic anhydrase inhibitors, but with very little success. In clinical practice, calcium channel blockers have too many side effects when used in a systemic fashion as oral medication, leading to generalized hypertension, and patients generally do not tolerate the calcium channel blockers. If you have to use this in a particular patient, I would strongly urge you to consult a cardiologist, so you don't end up with systemic complications. So generally it's not a thing to do at this point in time. There was some literature suggesting its usage 10-15 years ago, and no progress has been made since then. Carbonic anhydrase inhibitors as a vasodilating effectors in the eye is again a interesting concept. I mean, it's been shown in some animal models, but really speaking in humans, there is very little literature to suggest that it's making any difference. In terms of neuroprotective agents, again, it still remains a distant dream. NMDA receptor blockers, memantine has been tested and failed to show any efficacy. There were too many glitches in that study that Allergan put together several years ago, almost 10 years ago. And the endpoint, which is improvement in the Humphrey vision field testing in glaucoma patients while on memantine, they could never achieve the target, never show that endpoint, and so the study has been discontinued after spending millions of dollars on it. That should not discourage young researchers out there who are listening to this lecture to pursue this avenue of neuroprotection. I think the future belongs to neuroprotection. I really believe that there has to be a way for us to resuscitate these ganglion cells that are in the process of dying. And that will help not only in the eye, but also following brain injury and stroke patients, etc. So this is the next big challenge for a lot of you guys out there. Crack this puzzle, you'll be helping millions of people worldwide. So that concludes the lecture, but I want all of you to get hold of this paper, The Current Concepts in the Pathophysiology of Glaucoma by Renu Agarwal and co-workers, published in Indian Journal of Ophthalmology in 2009. Great paper that summarized all the concepts that we talked about in this lecture. I want you to read this on your own after you listen to my lecture, and I think that will consolidate the thought process behind this lecture, and that's the way to do it. Every lecture that I'm going to put together, I leave you with a classic paper that I want you to download from the internet and read. After you listen to my lecture, you read the paper, put together, I think you will have a much better understanding of the topic at hand. So I want to thank all of you for listening to this initial lecture in the Glaucoma lecture series. Please look out for more lectures on our Meditread website. Every week I'm going to record a lecture. Every week I will post a lecture, not only on glaucoma but other topics in ophthalmology. Our goal here is to create a resident lecture series that training doctors, training ophthalmology doctors across the world can use towards their training. Okay. Also, look out for our CME and board review courses that we're putting out. So if you have any comments, please email me at il@meditread.com. Thank you.